In this lesson, we're going to learn the clinical interpretation of ABG, or in short, arterial blood gas and oxygenation. So let's review the human anatomy of upper respiratory tract that causes pulmonary um, perfusion defects. No? So, kumukuha ng ABG or arterial blood for the part of the clinical or laboratory evaluation of our patient with pulmonary compromise. So, based on our anatomy, if there's certain obstruction or restriction, so the perfusion is affected. No, so as a evaluation of your hemoperfusion, your oxygen status is can be correlated or can be evaluated through ABG test. So let's recap the anatomy: the upper respiratory tract, the lower respiratory tract, and then the anatomy of respiratory tract includes the bronchopulmonary segments, the right lung, and the left lung. Middle lobes, the superior lingula, the lower lobe, and the superior and anterior and lateral posterior part of the left lung. So this is the ventilatory organs, which is considered also as thoracic pump. So the respiratory system is comprised of organs which may either play a role in ventilation of gas exchange. So pag may problema tayo sa ventilatory suction, so our gas exchange will be compromised. So the ventilatory organs are known as the thoracic pumps, are the central and the peripheral nervous system and the chest wall. So it's a bucket effect. No, if you review your basic anatomy, so the chest wall are composed of the thoracic cage, the respiratory muscles, and the pleura. So in cases of chronic obstructive pulmonary disease or COPD, so gas exchange is compromised due to uh, ventilatory defect. So the pumping mechanism of the lungs, particularly the gas exchange, cannot perform its vital role for gas exchange. So the perfect test for evaluation of your oxygen status is the ABG. So this is your ACM, the alveolar capillary membrane. It is the place where the gas exchange occurs. So gas exchange occur in the alveolar capillary membrane, or simply the ACM of your lungs. So what are the clinical manifestation of respiratory disease? So we have dyspnea or painful breathing. So if you have pain in performing breathing, so you can perform proper gas exchange. So we have cough, normal reflex for mucociliary escalating mechanism, or what we call pulmonary toilet, or the cough reflex. We have the chest pain and hemoptysis. As again, there will be a word confusion of hemoptysis and hematomesis. Guess, hemoptysis is coughing of blood, while hematomesis is vomiting of blood. Okay, there are some laboratory results like sputum analysis, culture and sensitivity. We have the ABG as part of laboratory evaluation. So ABG stands for arterial blood gas, and sputum cytology. So arterial blood gas, so we need specimen. It's taken from the arterial line or arterial blood. So hindi siya venous, no? So this is the blood is extracted from the artery or arterial. We have the arterialized capillary blood. The materials needed will be cotton balls, rubber syringe, heparin, sodium heparin, of or what we called heparin to prevent coagulation, anticoagulant, and ice for transport. So factors affecting levels of arterial blood gases: exposure to ambient atmosphere like air bubbles, it will affect the precision or accuracy of your test. Temperature of gas, we have the excess heparin. So more anticoagulant in the syringe, it will create or it will result to lower PCO2. by 12 to 25% in the actual result. So we have ice for transport. So the blood need to be soaked into the ice uh, for 30 minutes. Reference values for blood gas and electrolytes. So we have the basic normal ranges. So we have for pH, P stands for the poisson of hydrogen concentration, or simply the hydrogen concentration that ranges the normal value of 7.35 to 7.45. So we have the partial pressure of carbon dioxide, or your PCO2, which is 35 to 45, and your partial pressure of oxygen, which equals to 80 to 100%, and your O2 saturation of above 95%, and bicarbonate of 22 to 26. So take note, measure of ABG at 37 degrees centigrade. This is the room temperature. For each degree increase in temperature or in room air, the PO2 falls by 7%. Again, the PO2 or partial pressure of oxygen falls by 7%. It means bumababa ng 70% based on Act 1 in every increase in room temperature, and the PCO2 rises or tumataas ng 3% from the actual result. So this is the algorithm for you to review the acid-base interpretation. So you need to review this algorithm during your clinical exposure in the hospital. So you also review the Henderson-Hasselbalch equation. So it will be discussed deeper on your ABG formal subject. So if there will be a pairing of arrows, so these are the arrow pairing. So first you need to identify your pH. If the pH decreases, ano ang pair niya. So, if the pH decreases and your bicarbonates or ACO3 decreases, siya ang pair, no? Let's focus on that. Pag pair sila, they will be a metabolic, since each bicarbonate represent metabolic and pulmonary represent the respiratory status, no? So, if always pair your pH with the two what you call parameters. So usually pag ang pair ng arrow down is arrow down also with the bicarbonate, so sila ang pair, it will be a metabolic acidosis. Again, if there will be an increase in your pH, always first with the pH and paired with your bicarbonate, there will be an increase. So it is what we call the metabolic alkalosis, no? Metabolic alkalosis siya pag pareho sila. So together with what is the respiratory acidosis, so if there will be a decrease in pH, there is an increase in PaCO2. So that is what we call respiratory acidosis. Again, if there will be any decrease in pH, since it is an acidotic, so if there the parameters, if there will be an increase in your PCO2 in your result, it will be read as respiratory acidosis. If there will be an increase in your pH and there will be a decrease in your PCO2, it will result to respiratory alkalosis. So there will be an uncompensated respiratory acidosis if the bicarbonate, take note, is the bicarbonate will be normal and your pH will be decreased and your PaCO2 will increase, or PCO2 will the carbon dioxide will increase, and normal bicarbonate, it will be an uncompensated respiratory acidosis. If there will be a partial compensation, it should be the decrease in pH and increase in PCO2 and increase in your bicarbonate. So for your compensated respiratory acidosis, normal pH, normal bicarbonate, and increase in PCO2, it will be compensated. So if there will be a normal pH within the range of 7.35 to 7.45, then the status of the pH will be first evaluated in your algorithm in reading the interpretation. So next slide. So this is the arrow up, arrow base diagram for abnormalities and compensation. For respiratory acidosis, the carbon dioxide is increased, but the bicarbonate is alkalotic, no? For alkalosis, the status of your carbon dioxide, the result will be decreased. So since if there will be a decrease in PCO2, it is read as alkalosis, and there will be a decrease in bicarbonate. There will be an acidosis. So opposite silang compensation. If you observe increase, decrease in this is an alkalotic status of your PCO2, since it is respiratory, and this is your metabolic. So opposite sila palagi. If there will be a respiratory acidosis, you notice that there will be an alkalotic status of your metabolic or your bicarb parameters. So for metabolic or bicarbonate status, no. So if there will be an acidosis, there will be a decrease in your bicarbonate and decrease in your PCO2. So pag alkalosis in metabolic status, there will be an increase in metabolic or PCO or in your bicarbonate, and alkalotic, no? There will be an compensation that your PCO2 will be acidotic, no? Acidotic. So alkalosis ang metabolic mo, the compensation will be opposite. So the next parameters must be acidosis. So alkalosis, ang bicarbonates mo, it is above the normal range. So this is a metabolic alkalosis but the compensation must be opposite sa other parameters. So if the status is metabolic alkalosis, the respiratory status must compensate with respiratory acidosis. So in this case, a 26 years old female complaining for dyspnea, painful breathing, and a chest pain with a respiratory rate of 30 a cycle per minute. So the pH is 7.49. PCO2 is 30, the PO2 is 98, the bicarbonate is 24, the O2 sat is 99. If we observe the puissance of hydrogen concentration, it's 7.49. If we review the slides, the earlier slide, the normal range for pH is 7.35 to 7.45. So, ano to? 7.49 is outside the normal range because the upper limit is 7.45. Pero ang median, if you see the median of the range ng pH, di ba, 7.35 to 7.45, the median is 7.40. So 7.49, it's more on alkaline side or alkalotic, no? So alkalosis siya. So this is an arrow up kasi above ng 47.45 the upper limit. So sa pH, pag above limit, it is considered to be alkalotic. And then your respiratory status, which is your PCO2, is 30. The normal value for PCO2 is 35 to 45. So it is lower. So because the median is 40, so 30 is below the median value of the normal range, which is 40. So you consider to be opposite si PCO2. Pag less than siya, kinoconsider siya na alkalosis. Oh, so may pair na si pH. Since the pH is alkalosis, the PCO2 is alkalosis. Let's review the value of your metabolic, the bicarbonate. So the normal value of bicarbonate is 22 to 26. So 24 is normal, automatic by the rule. If there will be a normal value among these two parameters, so automatic, it will be uncompensated. What? This is uncompensated respiratory alkalosis. Uncompensated respiratory alkalosis is the answer for this case study. So, ang at room air, this is about oxygenation. If the patient is less than 60 years old, the expected value for PO2 in your ABG is between 80 to 100. So, patient above 60 years of age expected, the PO2, the 80, the minimum range, the lower limits will be minus 10 in every years above 60. So example, 61 years old, and every year there will be a difference, no? So minus 1 ang formula. So if the patient is 70 years old, you will subtract 70 to 80, which is the rule of oxygenation. In every patient above 60, the oxygen status will be minus 1. So the expected normal value at room air of your PO2 will be 70. So pag 70 siya, it is still normal because the patient is 70 years of age. So consider 70 is normal. But if the patient is below 60, it will be the 80 will be the normal parameters or the normal range for your oxygenation. So patient below 60 years old with a PO2 of less than 80 will be hypoxemic. So 80 to 100, it will be normal oxygenation. Above 100, it is more than adequate, no, in your interpretation. And the patient above 60, PO2 expected below is hypoxemic. PO2 is equals to 80 will be normal base if you subtract the age to 80, and then the PO2 above 100 is more than adequate. So different ang formula if the patient age more than 60 years old. So interpretations of oxygen status taken at room air. So there will be an hypoxemia if there will be a reading of 60 to 79 of PO in your PO2. Moderate hypoxemia for 40 and 59, and below 40 will be severe hypoxemia. So oxygen status taken patient receiving oxygen supplement. So adequate oxygenation, inadequate oxygenation, more than adequate oxygenation. So, a 66 years old chronic obstructive pulmonary disease patient, 5 days progressive dyspnea, painful breathing and respiratory distress with RR of 35 and ABG at room air. So, RA stands for room air. So, the pH is 7.32, PCO2 of 77, PO2 of 55. So, let's focus on the oxygen. So, with the age of 66, no? So, what will be your normal PO2? Sabi sa book, 80. But this is above 60 years old. So, 80 minus 6, that is 74. So, 74 will be the normal value acceptable in your PO2 in this case. So, sabi 80, di ba? Pero 72 is the normal range. So, the PO2 is 55. So what do you think the status of your oxygenation in this case? 80 minus 6, because it's above 60, no? If you get 6, there is an additional 6 years from the normal range of age. So 6, you subtract 80 from 6, 74 will be the normal. So we consider is in this case 55 as the mild hypoxemia. So partly compensated respiratory, so with moderate hypoxemia. Moderate is considered to be moderate because of the value of your PO2. So that's more about on PO2. So let's focus on the ABG interpretation. So how we interpret ABG as a review kanina, di ba? So again, let's review first the pH or the hydrogen concentration, or let's specific, the P stands for the puissance of hydrogen concentrate, no? So then, if abnormal, is it acidemia or alkalemia? So if the pH declines or decreases from 7.40 for the normal line, kasi 7.35 to 7.45. So kalagitnaan is 7.40. So if the pH or the puissance of hydrogen concentration decrease from 7.40, although it's compensated, it is acidemia, remember. If the pH from 7.40, which is the median, increases to 7.41 to above, it is considered to be compensated, but the nature is somehow is alkalemia. So that is the nature of your pH. So you need to first identify the status of your pH, then proceed to your PCO2. The PCO2 represent your respiratory status or parameters, no? So check for the PCO2 if it is respiratory or metabolic. So how will you can consider? So if it is paired with your pH, no? Kung acidemia, is it your PCO2 is also acid respiratory or metabolic? Check for compensation if the arrow is same direction. Check for the combined acid-base abnormality, opposite direction. So, tandaan nyo, if the arrows is opposite, it is somehow the anomaly of your reading for interpretation is combined metabolic and respiratory acidosis. And lastly, check for the oxygenation for room air. Diba at room air, as a rule, if the patient is below 60 years old, 80 to 100 will be the normal range for your PO2. So 60 to 79 will be moderate. Then 48 to 59 will be your moderate hypoxemia, and less than 40 will be your severe hypoxemia. Okay, let's review. The pH is 7.43 in this case. 7.43. So that is what within the range because the normal value for your pH is 7.35 to 7.45. So it is considered to be somehow compensated kasi nasa range siya. Pero based on 7.40, it is alkalemia. Kasi 41 to eh. 7.40 will be the median range, no? 7.41 is compensated because it is within the range. But it is somehow alkalemia. So the respiratory or the PCO2 is 34. The normal value for your PCO2 will be 35 to 45. So outside the range. So this is alkalosis, respiratory alkalosis. Kasi 40 ang median normal. So, the range is 35 to outside pa siya ng 35, less than pa siya. So, alkalemia. Opposite siya because pH if decrease is acidotic while PCO2 is the opposite of your pH. So, magkabaliktad sila. If there will be a decrease in your PCO2, it is considered to be alkalosis, respiratory alkalosis. So, your bicarbonate is 22 to 23 outside the range, no? Outside the range. So when it's outside the range, it's considered to be within the range siya, 22 to 23. So this is considered to be acidotic. So what will be the pair of your pH? Since your pH is alkalosis, PCO2 is alkalosis, and bicarbonate mo is somehow acidotic pero within the range. 'Di ba? 22 to 26 ang normal range ng bicarbonate mo or metabolic. Somehow, this is considered to be within the range and normal values. So it may appear to be uncompensated respiratory alkalosis. So answer normal acid base, normal ABG. It is considered to be the result will be normal base balance with normal oxygenation. Compensated, it is compensated respiratory alkalosis. Normal ABG with normal acid base balance with normal oxygen. Compensated respiratory alkalosis. Kasi yung partner ng pH mo within the normal range, 'di ba? Normal range siya, it's compensated, and your PCO2 is alkalosis. So these are alkalemia, alkalosis, acidosis, C bicarbonate mo. So the interpretation will be the final interpretation will be compensated because of your pH is within the range. It is compensated respiratory alkalosis with normal oxygenation because 50 at room air. Um, this uh, this uh, this PO2 of 90 is considered to be normal. No, so pH, PCO2. So this is considered to be normal compensated respiratory acidosis, respiratory alkalosis. So what are the causes of metabolic alkalosis? So the patient is more on a metabolic compromise, no? Exogenous steroids can cause metabolic alkalosis. Pag sinabi, what are the factors that contributes to metabolic alkalosis? Means that there is an increase in your bicarbonate, no, increased number or value on your HCO3 or bicarbonate. So possible causes that contribute to metabolic alkalosis with exogenous steroids, gastrointestinal loss or vomiting, pagsusuka, renal loss, decrease in chloride intake, diuretics and by too much diuretics, no, and bicarbonate administration and contraction alkalosis. So diuretics are these are drugs, pharmaceutical drugs that contributes to urination. So too much urination will contribute to metabolic alkalosis. What are the contributory factors that contributes to respiratory alkalosis? So we have hyperventilation. Bumaba yung PCO2 mo. If there will be a decrease and values or parameters in your PCO2, partial pressure of your carbon dioxide, contributory factors will be hyperventilation. Like for example, nag-exacerbate ka, if you're increase, there will be an increased physiology in breathing, it will create or contribute to respiratory alkalosis. Decrease value of your PCO2. So that is respiratory alkalosis. We have anemia, pulmonary embolism, sarcoidosis or sarcoid, anxiety, and pain. So pain is commonly the painful dyspnea or painful breathing. So metabolic acid-base disturbances. These are metabolic acidosis that causes are diarrhea, renal tubular acidosis, RTA, increase in iron cup, lactate, aspirin, uremia, and INH. So acid-base disturbances for respiratory acidosis means increased level of your carbon dioxide or PCO2. So hypoventilation or shallow breath will contribute to increased PCO2. COPD or chronic obstructive pulmonary diseases, Pickwickian syndrome. So Pickwickian syndromes are ito yung sa obese person or in layman's term, Pickwickian syndromes represent short neck, no? So these are obese person with short neck. So obesity, it will create an respiratory acidosis. There will be a retention of your PCO2, suffocation, drowning. So there will be a respiratory acidosis, opiate overdose, opium, no? So na-overdose ka ng opium or other drugs related to opioids. So it will create an increase in your PCO2 level and sleep apnea. If you snore, short neck din, mataba ka, if you have an OSA or obstructive sleep apnea, it will also contribute to increase in your PCO2, which is called the respiratory acidosis. So that is the end of the slide for the interpretation of ABG. So thank you for the time for this topic, the ABG interpretation. I will be giving the slides to your emails, and please do self-reading of the PowerPoint slides for your reference for your exam during finals. Thank you.